Hi, hello to everybody. We are going to start the symposium now. Thank you very much, everyone, for being here. Good evening to all who connect from Europe. Hello to the attendees from the US and other parts of the world. Buenos días a todos. Bona tarda a tothom. Welcome to everyone. We are now going to open the first symposium in combination therapies in common diseases, clinical and translational challenges. This symposium is organized within the framework of the European project named Decision on Optimal Combinatorial Therapies in IMIDs using System Approaches, shortly named with the acronym DOCTIS, the DOCTIS project. The DOCTIS project, as I told you, is founded by the European Commission through the Horizon 2020 call, the call named System Approaches for the Discovery of Combinatorial Therapies for Complex Disorders. The DOCTIS project is made possible thanks to a consortium of participating entities from Europe and from US that you can see in this slide. The project is led by the Fundació Hospital Universitari Vall d'Hebron, Institut de Recerca Vall d'Hebron, here in Barcelona, which is the project coordinator through Dr. Julià and myself. Professor Michael Benson from Linköping University, Sweden, is the responsible from the system level analysis using the Learning Disease Models framework. Dr. Jorge Alheim from Fundació Centre de Regulació Genòmica, el CNAC-CRG, also from here, from Barcelona, is the responsible from the generation of the huge amount of data using single-cell RNA-seq that we are going to generate in this project. Professor Ernest Choi, a rheumatologist from Cardiff University, will be responsible from the clinical study validation of combinatorial therapies that we have had identified in the previous stage of the DOCTIS project. Professor Pere Santamaria, from el Consorci d'Institut d'Investigacions Biomèdiques August Pi Sunyer i d'IVAPS from here, also in Barcelona, is responsible and leading the preclinical validation of combinatorial therapies. Professor Giampiero Girolomoni, a dermatology from Universitat degli Studi di Verona, Italy, is the dermatology expert in psoriasis. Professor Giampiero is the dermatology expert across all the stages of the project. As well, Professor Abrita Sigmund from the Charity Hospital from the Berlin University, Germany. She's a gastroenterology expert in IBD, in Crohn's disease and ulcerative colitis, and she is the expert in gastroenterology through all the phases in the study. Dr. Richard Myers from US, the director of Hudson Alpha Institute for Biotechnology, Huntsville, Alabama, US, is also responsible from the generation of multiomic data in the project. Dr. Manuel López Figueroa from Imidomics SL is responsible, the company, for the development of a personalized therapy biomarker for these diseases. And finally, Zavala Innovation Consulting, led by Laura Sesma, is the project manager of the project. Very briefly, I would like to introduce you the scope and the main objective of the DOCTIS project so it can be contextualized within the present symposium. DOCTIS project is aimed at addressing the urgent need to discover effective therapeutic strategies for immunomediated inflammatory diseases, IMIDs. IMIDs, as all you know, represent the third most common type of disease in developed countries, and there is no cure so far. They have a common genetic background and tend to share many therapies. Despite of this, none of the current therapies can reach a permanent disease remission, and there is, as I said, no cure so far. The DOCTIS project aims to discover effective therapeutic strategies for IMIDs in a personalized way and proposes a novel system-level approach to identify the best drug combinations based on integrating biobank, omics, system analysis, preclinical studies, and clinical trials, all of them at the highest standards of quality. At the end of the day, it is our objective to provide a clinical proof of concept that by gaining a systems level knowledge of the pathophysiology of IMIDs, we can achieve a precise prediction on the optimal combinatorial therapies for a given IMID patients. This is in the context of the symposium and the DOCTIS project. Before to move the presentations, I would like to thank all the DOCTIS partners for their commitment to the project to help us to organize the symposium. Thanks to all of them for bringing very good science to the symposium. Thank you very much to all of you. I would like also to thank IMIDomics to sponsor this first symposium in combinatorial therapies in IMIDs. IMIDomics is a drug discovery company in IMID diseases, is a leader company in this field, in IMIDs area, that integrates clinical, epidemiological, biomolecular data, and advanced analytics to identify new targets or new applications for existing compounds based on very well precisely defined patients. Finally, I would like to thank all the medical specialists and many thanks especially to all the patients. We are really convinced that the effort like the DOCTIS project and the projects you will see today in the symposium will improve the quality of life of millions of patients in the near future suffering chronic, disabling, and complex diseases. Thanks to all of you. Thanks to all of the attendants. We hope really that you enjoy with the science, with the talk in the symposium. Let's move on to the science. Let's move on to start on the symposium. Now, we are going to initiate the first block of the presentations, the clinical challenge, with the first speaker. The first speaker is Cristina Saura. Cristina graduated in medicine from the University of Barcelona in 2002. She completed her clinical training at the Harvard Medical School in Boston in 2007 and became a doctor of medicine from the Autonomous University of Barcelona in 2017. She is currently the head of the breast cancer unit at the Medical Oncology Service at Vall d'Hebron University Hospital, where she leads a large team of clinicians and scientists focused in breast cancer precision medicine. And I would like to tell you, and I'm so proud that she is a world reference in breast cancer in pregnant women. I'm so proud to say that, because as you can imagine, to lead with this difficult and challenging situation is very, very difficult. And she really is a world reference in this particular condition. So Cristina is going to tell us about precision medicine in advanced breast cancer. Cristina, thank you very much to stay today here with all of us. So you could start when you're ready. You have 20 minutes.
Okay, thank you, Sarah, for this kind introduction. Sorry, because I'm not get used to this platform, and you have to help me to share the screen. Could you guide me on that, or you can share the presentation?
Carla,
Cristina, you should be able to share now your screen.
Sorry, because does not seem to work. Does not seem to work. Let me.
I have to tell you that Cristina was very worried in WhatsApp with me because she was in a traffic jam from the hospital. She called me, Sarah, I will be on time, but she was worried the traffic today here in Barcelona, and we didn't have any minute to try.
Yeah, Sarah, I think it's easier if you share the presentation that I send you.
So, Carla, can you do it, please?
Yes,
Because
sure.
I have to, yeah, because I have to leave the.
I know how is the traffic here at the time of the school. Don't worry at all. It's a pleasure to have you here, honestly.
Yeah, so thank you so much, and sorry. Yeah, sorry for the inconvenience. I'll let you know when we have to move the next slide. So thank you, Sarah, for inviting me to this very different symposium. So I think that the most important thing that I can share with you is the experience that we have in precision medicine in advanced breast cancer. We've been dealing with all the challenges of precision medicine, and as I understand, you are trying to do with this initiative something very similar for patients with rheumatologic diseases. So it's very interesting for me to hear your perspectives also, but I'll try to share in the next 20 minutes our experience. Let's move to the next slide, please. For us, precision medicine in metastatic breast cancer is a different approach to the disease that takes into account individual variability genes, environment, and lifestyles for each person. And the main objective, once we started working on precision medicine, was to identify targetable driver mutations in order to guide diagnosis, inform prognosis, and mainly support treatment decisions. We have defined, let's say, different applications for precision medicine in breast cancer. The first one would be to identify drivers of the disease, and we are now able to define if within breast cancer, some types of tumors that are guided by different mutations. And the second important application that we have for precision medicine today is to characterize the resistant clones of some cells, and then we are able to target that mutations that appears a resistance mechanism. Let's move to the next slide, please. With all that in mind, there have been in the last, let's say, 10 years, a huge amount of protocols worldwide trying to address the question of how to apply in the practice precision medicine. And I must say that it's not easy. You can see here a map trying to address this issue. And you can see that there has been a lot of initiatives worldwide. But we have to deal with different caveats. In breast cancer, we have to deal with intratumor heterogeneity, and not only with that, knowing that there are different mutations in the same tumor, we also have to deal with tumor evolution. And we know that the tumor may acquire some of these resistances through the evolution and as a mechanism of resistance under pressure of the treatments that we get to the patients. We learn also that the genomic biomarkers that we use to understand or to target the treatments in the clinic are different. We may use a single gen determination, for example, with a digital drop PCR that it's very sensitive, but it's only looking for one single gene, or we can use on the other side germline and multiple testing in platforms that are now available in the clinic. But this is not the same. We have to be aware about the information that each of the tests that we can perform will give us. And at the end of the day, we have to interpret that results and know about the sensitivity of each of these tests. And last but not least, we are now dealing with a new caveat that it's in which tissue it's better to perform the analysis. So it's better to perform the analysis in the tissue of the breast or origin tumor, or it's best to test that mutations in the metastasis, or we may move to also to the liquid biopsy. That it's also a new important tool for us in the clinic because it's easy to analyze, but we are learning on the way how to interpret also the results. Next slide. In the last, let's say, 5 years, we learn, or we are trying to learn how to use that in the clinic. And the Aurora trial, it has been, and it's an ongoing program that make a huge effort trying to address for patients with metastatic breast cancer an analysis of the primary tumor, of the metastasis, and also ctDNA extracted from plasma, trying to learn about the different information that we can get from each of these different samples. You can see here that the first results were published in Cancer Discovery a couple of months ago, and you can see here the different, an oncoplot with the different mutations that we can find in the primary and metastatic tumors, and also we can see here what we have learned from that. We know now that about 88% of the mutations are shared from the metastasis and the primary tumor, but we also learned that around 10% of the alterations are acquired in the metastasis. And now we are learning which of these mutations appear as a mechanism of resistance. For example, as you can see here, ESR1 mutations are clearly acquired for patients with hormone receptor positive HER2 negative disease under pressure of patients treated with aromatase inhibitors. Next slide, please. Trying to understand how to use that in the clinic also, ESMO, the European Society for Medical Oncology, established a scale for clinical actionability of molecular targets, that it's a SCAT scale, that it's very easy to use in the clinic and classifies all the alterations that we may find in those different panels in different tiers, and are differentiated depending on the, you can see the definition here. For example, for tier 1 alterations, we know that we have clear results from clinical trials that improved outcomes for patients in the clinic. The clinical implication in 2021, it's that the access to treatment should be considered a standard of care. And you have here the alterations included in that tier for breast cancer, that are RBB1, RBB2 amplifications, germinal BRCA1 or 2 mutations, PIK3CA mutations, microsatellite instability, and NTRK translocations. Next slide. In the Aurora trial, it has been assessed how many of these alterations that has been found for the patients analyzed, and you can see here that only 38% of the patient has any of these considered tier 1 alterations that should be considered for standard of care of the patients. And if we consider the next evidence level, up to 50% of the patients may have an alteration targetable in the clinic. But at the end of the day, this is not enough, because we can see here that only 7% of the patients included in the Aurora trial received a matched therapy matched to the genomic alteration that it was founded in the program. So there are a lot of caveats to have that precision medicine in reality. We have a lot of limitations, so the access to clinical trials, and this is something that I can envision that you have the same problem. So clinical trials are not accessible for all the patients worldwide, because only in some selected sites we have the ability to conduct these clinical trials. And also after the approval, this is not equal worldwide, and we have some drugs approved here or in other countries and not here yet. Next slide, please. So in breast cancer, as you know, and we are in October in the month of breast cancer, the patient empowerment is really an important issue, and it's forcing us as investigators to move forward, and this is amazing. For example, in the US, there is a program that it's it's called Metastatic Breast Cancer Project, Counting Me. And in that project, patients give their samples from metastatic tissue just only for learning purposes. They are not receiving any benefit on that, but they really want and help to understand the mechanisms of resistance and all the alterations that they have in their tumors to help us to move forward treating them better. And one of the limitations, I'm part of the scientific committee and the board of directors at SOLTI, that it's a cooperative group here in Spain dedicated to breast cancer treatment. We detected that one of the limitations it's that sometimes the patients are not very well informed about the options to arrive to clinical trials. And we started the whole trial, that it's a trial in where the patient, themselves are included through a digital tool in this program, and then they manage the samples, the tumor samples, and they go to different labs to perform a blood test, and foundation analysis and a Guardant analysis are performed. And then once the results are analyzed, the patient receives those analyses that themselves share with the oncologist. So this is a new approach, and we are trying to see if putting the patient in the middle of this analysis of the alterations that the patients may have could help to improve the percentage, around 10% of the patients that even having a targetable alteration receive match therapy in the clinic. Next slide, please. So I go through that very quick because I don't think that it's important for you, but for example, the alterations that we have in the Tier 1 alterations are the PI3K mutations. We have a phase 3 trial that compared patients with PI3K or wild type tumors, and we know that there is a clear benefit in progression-free survival and also a trend in overall survival. And alpelisib, that it's a PI3K inhibitor, it's now approved in the clinic in the FDA, and the EMA also approved that therapy, not yet in Spain, but in many countries it's approved. Next slide, please. We do have also evidence for patients that carries germline mutation, BRCA1 or 2 mutations. We have 3 different phase 3 trials comparing PARP inhibitors for these patients, comparing that with physician's choice, that are different options of chemotherapy. And the 3 trials testing different PARP inhibitors, niraparib, olaparib, and talazoparib, gave very similar results with a clear increase in progression-free survival and with better quality of life for patients compared with chemotherapy. So these PARP inhibitors are starting to be approved in the clinic depending on different stages of approval depending the countries. Next slide. Other alterations, so this opens also a question about how do we have to test the patients in the clinic. Up to now, before having this PARP inhibitor for patients having these germline mutations, we normally send the patients to genetic counseling clinic depending on clinical criteria. Let's say different members of the same family with breast cancer or breast cancer associated with ovarian cancer. And then if they define enough probability of having these alterations, they perform the genetic testing. Now we are changing our minds. And as this has been a target for treatment on the clinic, we are changing our strategies, and we are starting to test patients with different strategies. But I think that we are moving to a universal testing for all the patients in the clinic to find these alterations. Next slide, please. Other issues to consider, it's the effort that we have to do to run these pre-screening programs to find some very unlikely alterations. You have here the example of these 2 alterations that are included in the Tier 1 SCAT scale that we've seen before. So this should be theoretically offered to all the patients with these alterations, but as you can see here, for example, the mismatch repair deficiency in breast cancer is very uncommon, around 1.7% of the patients, and even the FDA-approved pembrolizumab for this patient population, it's not easy to offer or to screen all patients trying to find these very unlikely alterations. Same with NTRK fusions. There is also larotrectinib as an FDA-approved drug for these patients, but again, this is even less uncommon, less than 1% of the patients. So it's difficult, and we can discuss that on the questions and answer section, how to deal with this program and these very uncommon alterations. Next slide, please. But I think that we learn a lot. For example, this trial, it's an example, the Cleopatra trial. It's the trial that led to the approval to pertuzumab, that it's an anti-HER2 therapy for breast cancer. In this trial, we learned that patients treated with chemotherapy plus trastuzumab and pertuzumab was better than treating the patients only with one of the antibodies. So you can see here that the patients with receiving pertuzumab have better progression-free survival, but we learned that patients with PIK3CA mutations do worse even receiving the best therapy. So now in the clinic, having that in mind, there are 2 trials that are now in the clinic testing different PI3K inhibitors and trying to improve that progression-free survival for patients with PIK3CA mutations. So we're learning about precision medicine using the biomarkers that we learned from previous clinical trials. Next slide, please. But this is not easy. We have to deal, as I mentioned, with the biomarkers that are available in all the countries, and this is not the same in all the countries, and huge differences depending on the country, and also the availability of the medicine. And you can see here that, for example, in Spain, we do have quite good access to drugs, but we are, let's say, in the middle about the quality of or the access to biomarkers to get these drugs. Next slide, please. And at the end of the day, what is the impact of that clinical decision based on precision medicine? So we still have to improve a lot. For example, in this trial, that it's not dedicated only to breast cancer, it's dedicated to any any tumor, and even finding some alterations, the trial was not able to determine that the patients treated, guided by these alterations, are treated better or live longer than the patients treated with the standard of care. And you can see here that the time spent on that alterations, it's also important and have to be taken into account for that patient. Next slide. And here, in numbers, we can test 100% of the patients, but the succeed in testing, it's around 80%, because sometimes the samples that we get from the patients are not enough to perform that analysis. Then we have around 50 to 70% of patients with targetable mutations, but at the end of the day, it's only around 10% of the patients that initially was willing to receive some personalized therapy, receive treatment guided by these alterations. Next slide. And with that, my conclusions. So precision medicine paradigm in metastatic breast cancer contributes to the comprehensive care of the patient, and not only the patient, also her family, and it's a reality in 2021. In breast cancer, we have very clear definition of the alterations that should be determined in the clinic. From the perspective of clinical research centers, and considering the high number of level 2 alteration, it's important to include metastatic breast cancer patients in molecular screening programs and include them in trials testing targeted therapies matched to genomic alterations. And we are very fortunate to have that opportunity for our patients at Vall d'Hebron. But finally, from public health perspective, NGS-driven approach is not yet feasible for all health systems, and NGS or comprehensive genomic profiling still comes to a cost that it's not universally covered. And last slide, please. My conclusion is that one size does not fit all. You can see here that if we do the same exam for different animals, not all of them will have the same note in the exam. And I want to thank also my team for being possible, all the trials and all the things that we are learning from the clinic. Thank you so much.
Thank you very much, Cristina. Every patient has to be treated as an individual human being, right? Every patient. Okay, so thank you very much, Cristina, for this excellent talk. I really appreciate, and also you sticking the time. So thank you very much. So I have to tell to you, well, you already know, but all the audience that do you have a tab on the webinar, a questions tab, where you could put all your questions. So after the end of the third speaker, after Adrian Mander, we will open a question and answers minutes, about 10-15 minutes, and we will come up with all the questions that you have put in the questions tab. So from this moment ongoing, you could add your questions at your best convenience. Okay? So thank you very much, Cristina. So we will move to the second speaker. Second speaker, Bram Bredscott. He's going to talk about the combination strategies in IBD. Hello, Bram. Opportunity or challenges? This is the question. No? Bram Bredscott graduated to medical school at the Leuven, Belgium University in 2013. During his PhD, he worked at the University of Cambridge, at United Kingdom, in the lab of the Professor Kenneth Smith. In 2021, he graduated as a gastroenterologist and joined the IBD staff as clinician and scientist at the Gastroenterology Pathology Department at the University Hospital Leuven in Belgium. His translational research mainly focuses on the development of predictive and prognostic markers for a more personalized medicine in IBD, as well as unraveling IBD disease heterogeneity through multi-omic approaches. Additionally, Bram does clinic research and monitoring tools, real-life IBD data, and is involved in various international studies. Bram is a board member of the ECO Committee and co-founder of the Colibri Proteomics Consortium in IBD. So thank you very much, Bram, for staying today with here. You could take your times, 20 minutes, talking to combination strategies in IBD, opportunity and challenge. Thank you very much to stay here. Take your time.
Thank you very much, Sarah, for the kind invitation. Good evening, everyone. So I'm not Séverine Vermeire, who was initially scheduled at the program, but unfortunately she couldn't make it. There appears to be a problem with my slide, so I don't know if you can ask me again to share, because it worked when we tested it before, but now I got an error. So if not, we can use the slides you have, but they do not include the patient pictures I had in my presentation.
You can try again.
Okay, yeah, so now it works. Can you see my screen?
Yes, I can see it, Bram.
Perfect.
Okay, thanks.
So good evening, everyone. So in the next 20 minutes, we will talk about inflammatory bowel disease and combination therapies. So I think we already got a brilliant introduction on where our colleagues from oncology are when it comes to precision medicine. I think that's something we are all dreaming of in IBD, but there is still a long way to go. So, and of course, if we talk about combination therapies, then I think one of the first questions which always comes up is whether any benefits outweigh the risk, because we of course know, and we'll discuss that later on, that there are obviously some risks with the immunosuppressant therapies we are administering, and especially if we combine those, there might be a potential increased risk. So I think we should always try to balance that, and that's not just something particularly for combination therapy. I think as clinicians, that's what we always try to do, to balance that risks and benefits for our patients, because we want to improve them, we don't want to make them worse. So why don't we need these combination therapies in inflammatory bowel disease? Why should we consider to take that potential risk. Because if we look at the IBD therapeutic landscape currently, then we see that it's getting more and more crowded. Back 20 years ago, end of the 90s, we only had one anti-TNF therapy, but now we have many more treatment options. We have vedolizumab, an anti-integrin. We have the first JAK inhibitor on the market, tufasitinib. We have ustekinumab, an anti-IL-12/23. And in the next years to come, we will have many more options. Ozanimod is an S1P receptor modulator, is the first in class which will come onto the market end of this year, early 2022. And as you can see here on my slide, there are many more compounds to be expected quite soon in the years to come. So our therapeutic armamentarium is clearly growing. Why should we aim to have more drugs, and why are we considering combination therapies? So, and the reason for this is basically that we are plateauing. If we look at the efficacy rates of all the different drugs which are currently on the market or are in late stage development, and we see that none of those basically exceed what I would call a therapeutic ceiling of about 20 to 25, maximum 30%. So this is an overview which one of our PhD students recently made to visualize it, and I think it clearly emphasizes the therapeutic gap we are currently facing in IBD. And there are many ways how we should try to improve that, and one of that is definitely precision medicine, where I strongly believe in, and another one as part of that precision medicine part is definitely considering combination therapies. So that therapeutic gap I've just been talking about can actually be even larger if we think that some of our patients not just have one immune-mediated disorder. They might have Crohn's or ulcerative colitis in combination with, for instance, psoriasis, in combination with axial or peripheral spondyloarthropathy. So many of our patients are treated in a multidisciplinary approach, and I think that's also very valuable today to have clinicians and basic scientists from different angles, because we need to treat these patients and try to embrace them in a multidisciplinary approach, because that's the only way we can bring them forward. And I will just give you very briefly one example to show you why it's important to have these multidisciplinary discussions and why it might be important also in these specific patients to consider combination therapy. So this is a patient which was diagnosed back in the 90s with morbus Crohn. She needed repetitive courses of steroids, because at that time we only had steroids 5-ASA at that time still considered for Crohn's disease and the immunomodulators, but she didn't do that well on the immunomodulators in terms of side effects. She developed abnormal liver tests, so she stopped azathioprine, and in the meantime she developed joint pains compatible with also a concomitant diagnosis of spondyloarthropathy. So in the years to come, after having stopped azathioprine, she had a relapse of Crohn's. She was switched to steroids again, and then ultimately ended up with methotrexate. But then using methotrexate, she developed some side effects, and then it was beginning of the nillies. She was put on infliximab as one of the first, for which she responded quite well to that anti-TNF therapy, but it had to be stopped due to pregnancy. At that time, there were very little data on whether it was safe to continue it during pregnancy or not. It was restarted, luckily without any infusion reactions afterwards, and it was withdrawn a second time for a second pregnancy a few years later. And then after a second pregnancy, she preferred to have a subcutaneous therapy, so she was switched to adalimumab, which we had to discontinue almost 10 years ago because of a loss of response despite very high doses. So it seemed that she was losing response to anti-TNF therapy. And because at that same time she had a progressive stricture in her large bowel, it was decided to basically resect that stricture, because we could not further surveil, we couldn't do any surveillance for colon cancer beyond that stricture, which was a danger on top of the inflammation she had. And it was decided to go for surgery because she was not responding to anti-TNF at all, and we didn't have any commercial options at that time. So we stopped the anti-TNF. She underwent the surgery, but a few years later, she again developed joint pains because of the spondyloarthropathy. And they could be resolved with infliximab. So infliximab was reintroduced. However, her Crohn's was no longer responding to that anti-TNF therapy. So we had to switch out of class specifically for the Crohn's. She was switched to vedolizumab, which is a gut selective agent. Unfortunately for the GI tract, there was a primary non-response, and on top of that, her joint pains were not well controlled. So ultimately, back in 2016, we put her on ustekinumab, and ever since, she's doing great in terms of her bowels. However, she developed severe sacroiliitis, and that's the time we discussed in multidisciplinary with the rheumatologist to associate etanercept on top of the ustekinumab. She's doing great, but I think with what we know now, it might have been if we would have had the options we will have in the next years. Presumably, after discussing with our rheumatologists now, we might consider it differently. We might go for a selective anti-IL-23p19 if the rheumatologist would believe that that might have some benefit for the joints, or alternatively, we might go for one of the more JAK1 selective inhibitors, which will soon become available, and which might also be a valid option for both the Crohn's as the rheumatology. So there are clearly cases and there are clearly patients who need that combination therapy. So what have we learned from the past when it comes to combination therapy? Because now we are thinking about combination therapy as a combination of biologicals or a combination of a biological and a small molecule. But basically in IBD, we've been applying combination therapies for quite a while. If we look back to the old literature on 5-ASA and ulcerative colitis, then we know that the combination of oral 5-ASA with rectal 5-ASA is much stronger in inducing remission in patients with distal ulcerative colitis as compared to a local therapy or a monotherapy with oral 5-ASA alone. So the combination therapy for 5-ASA we know for quite some years. The same applies to the combination with infliximab and azathioprine as an immunomodulator. So this is, I think, the SONIC trial, one of the landmark trials in IBD for the past 10-15 years, where it was clearly shown that if you combine both therapies, that the outcome will be much better. And nowadays, of course, we understand that this is to do with immunogenicity, but that was not so strongly known back in 2010. And it clearly shows as one of the first randomized trials that combination therapy might improve outcomes in IBD patients. However, it's not always a success. So it's not because drug A and drug B work that a combination of both will basically result in a better outcome. And this, for instance, is the case. This is just one example where it was clearly shown in a meta-analysis that if you compare anti-TNF monotherapy versus anti-TNF therapy plus corticosteroids, that there is no additional benefit. Instead, combining both, especially the steroids, we know that they have a huge range of side effects. So it might well be that on the long term, we basically do more harm than we will actually induce a benefit for the patient. And finally, if we look back at the past, we have learned that some combinations can be bad and dangerous. And remember what I've said in the beginning, we always want the best for our patients. We have to make that risk safety analysis time after time, so the efficacy and the safety should be balanced. And one example is, for instance, the combination I've just shown you. So I've told you that with the SONIC trial, we could clearly demonstrate that combination therapy is superior to immunomodulator monotherapy or infliximab monotherapy. However, the counter side of that is that there is an increased risk for infections. This is a large study from US and France where they looked at serious infections and opportunistic infections, and you can clearly see that in patients with combinatorial therapy with anti-TNF and a thiopurine, that there is an increased risk for infections. And there is more than just infections. These patients, and this is coming from a large registry in France with almost 200,000 patients. This is a registry where they compared thiopurine monotherapy versus anti-TNF therapy versus the combination of both, and looked at lymphoma, and you can clearly see and at the adjusted hazard ratios that basically if you combine both, that especially in a subset of patients, and we know that this is presumably all patients above 65 years, that there is a significant increase in lymphoma, and this is obviously even worse than the opportunistic infections I've spoken you before. So finally, where are we currently when it comes to combination therapy in IBD today, and what's the future look like? So there are many options. I've just showed you that our therapeutic armamentarium is rapidly increasing, and we can combine a lot of things, not just specifically focusing at IBD, but as I've shown you the example before, it might also well be that there are some safe and effective options for patients suffering from IBD with a dermatology problem or with a rheumatology problem or another immune-mediated problem. So theoretically, at least, there are various options for combinations. But what do we know? So far, we only have case series in IBD. So this is a very recent meta-analysis where they did a lot of literature search, and they identified various case series. And in terms of serious adverse events and in terms of efficacy, it seems so far quite reassuring, I would say. But of course, these are data which are not well controlled. They are mainly driven by retrospective descriptions of patients in very selected cases. So this is something we need to address as a field much more in depth in the next years before we can draw any final conclusions on the efficacy and the safety. And one first trial, which is currently ongoing and almost about, I think the data will soon be open in public. This is the Explorer trial, a phase 4 trial where patients are quite, I would say, quite heavily immunosuppressed in the first months. So they receive vedolizumab, an anti-integrin, together with adalimumab, an anti-TNF, and methotrexate for 26 weeks, where the primary endpoint of the trial will be. And then patients will go on to vedolizumab monotherapy. So the idea of this trial, it's an exploratory trial. That's why it's called the Explorer trial. So the idea is to bring patients very quick in deep remission with quite some aggressive, I would say, immunosuppressive therapy, and then continue with the maintenance therapy afterwards. Another trial, which is a phase 2A trial, with guselkumab, a novel anti-IL-23p19 antibody. This is a trial in patients with ulcerative colitis, where guselkumab will be compared to golimumab, an anti-TNF agent subcutaneously, or the combination of both. So these are two examples that there is indeed something moving in the IBD field, and that we will soon have data on combinatorial therapies tested in a randomized manner. And of course, as I've said you before, we have new modes of actions coming onto the market very soon, and then we can, at least hypothetically, we can think about what would be a reasonable combination in terms of efficacy and in terms of safety. Of course, if we think about potential efficacy, then we will consider the modes of action. And this is just one example of the S1P receptor analogs, which will soon be introduced in ulcerative colitis first. It might well be that is, at least from a mode of action point of view, that it might make sense to combine it, for instance, with an anti-IL-12/23 or with an anti-TNF. However, we will have to monitor very closely, if we start these combinations, the safety. And on top of that, and I think that's the most important thing, so I've just told you that hypothetically that might be an option, but I think where the field absolutely has to go to is even further molecular phenotyping. And that's, I think, something we should learn from the oncologist, and we just had a brilliant introduction and presentation on that. So in my beliefs, what we should do much more, and this is a common theme which interests me a lot, and many people in the field are doing research on this more and more, luckily, I would say, is that we need to tackle the disease differently. And what we should do is try to much more go into the details of the molecular biology of patients and look for that molecular fingerprint. So then we can ultimately not just run our trials in a one-size-fits-all principle, because that's not working, and that's why we are facing that huge therapeutic ceiling. But what we should do is, first of all, try to identify molecular subgroups of patients, and then in these subgroups of patients then go for very dedicated trials with a compound which is specifically focused at the drivers of the disease in that molecular subgroup, or not just one compound, but potentially also multiple compounds. So start our monotherapies and our combinatorial therapies much more in an intelligent, molecular-driven way. And I think by doing this, we might even reduce the sample size in our studies, because the delta we should expect might be much higher, because we start with an enriched population of patients. And if you compare it to placebo or to different drugs where we don't expect that a compound would work based on the biology, then at least we could come to much quicker results. And I think then we can go where the field should go, is towards an effective compound with companion diagnostics, so we can at least have a better view on what is the best drug for the for a given patient. But of course, and this is, I'm coming to the end of my story, there is more than just, of course, the immune system. So the vast majority of the drugs we are currently testing and launching in inflammatory bowel disease are specifically focused at reducing that inflammatory burden, which is obviously very important, because that's where our patients are suffering from. But IBD is much more. IBD is a complex disease where also the environment plays a role, where the microbiome plays a role, and there is obviously also the interaction with the genetics. But we are largely not, I would say, disregarding these three different parts of the pathogenesis, and we are focusing only on trying to dampen that inflammatory burden. But I think when we think about combining therapies, we should evolve and think out of the box beyond combining simply anti-inflammatory agents. I think we should also think smart about combining an anti-inflammatory agent with a diet intervention, for instance, of other ways, other modifiers. And this is just one example of a randomized trial which we just have launched here in Leuven, and which is driven by one of my colleagues, João Sabino, where we will all Crohn's patients who need to start a biological because they have clearly active disease ongoing, we will randomize them between a group of patients who, the control group, who are just treated with a biological agent, and a second group which will have as an add-on a very intense follow-up by our dietitians, and where we will give a lot of advice and try to enforce them to follow a very rigid diet. I would say what we call the fit diet is a diet which we developed previously, and where we could show both in patients with UC as in healthy volunteers that we could further dampen that inflammatory burden. So the combination of both, and we are really looking forward to the results to see if we can, with diet, basically aim for an additional benefit as on top of what the biological should do. So finally, I would say there are various ways to think about combining therapy. So we could think about it as independent modes of action where there is no direct anti-inflammatory effect. And one of these examples is the one I've given you from the SONIC trial, where there is your infliximab as main anti-inflammatory agent and the azathioprine, which is increasing the efficacy of the infliximab by intervening with the immunogenicity. Then we have other modes of action where there is huge overlap, and probably the additional benefit will be quite limited, instead of when there is medium overlap, or ideally when there is basically where the two therapies you're combining are basically very complementary. And that might be, for instance, the case with interventional studies where we combine an anti-inflammatory agent with dietary modifications. And I think there is a lot of research more to be done in this field of combinatorial therapies in inflammatory bowel disease. And one of, I think, the people who is driving a lot of the research is Jean-Fred Colombel, who was so kind to share this slide also with me today. But I think he's doing brilliant work specifically on trying to unravel how we could optimize these combinational therapies in inflammatory bowel disease. And with this, I would like to conclude and say that indeed combination of traditional therapies have a very long history in inflammatory bowel disease, as I've shown you, and that the combination of anti-TNFs with thiopurines clearly illustrate the potential benefits, but also highlights the potential risks when we think about combination therapy. Combining biologics with different modes of action may help us to improve efficacy, and we will have to await the trials. But the main obstacles still are the uncertainty about the safety and the costs, and therefore, in order to try to optimize efficacy and hopefully also to minimize safety issues, we should try to understand much more in depth the biology of our patients, and then start from there combining therapies in a very smart way, and also think out of the box beyond just combining anti-inflammatory therapies. And with this, I would like to conclude. I'm very happy to, in a Q&A session, answer your questions. I would like to thank you for your attention, and I also would like to thank and acknowledge all our colleagues here in Leuven who are doing a lot of the research together with us. Thank you for your attention.
Thank you very much, Bram, for this excellent talk. Certainly, we have to wait the first trials in gastroenterology, because at this point, at this time, gastroenterologists are you leading the area of combinatorial therapies in IMIDs. You are further than dermatologists and rheumatology at these times. So congratulations for all your job and these gorgeous presentations. Thank you very much, Bram. So let's the audience to give to put the answers in the questions tab. And meanwhile, we are moving to the last presentation from this first block. It's also my pleasure to introduce the new speaker. The new speaker is Adrian Mander. Adrian is the Director of the Statistics and Professor of Medical Statistics at the Center for Trial Research at Cardiff University. He did his PhD in Spatial Game Theory in Sheffield University in 1995, and then had a postdoctoral position at the London School Medical in the Statistical Group until 1997. He worked at the Medical Research Council Diagnostic Unit on problems in statistic genetics, and also at GSK in their clinical pharmacological group. He took up a position in the Medical Research Council Human Nutrition Research Unit as head of statistics, and returned to the Medical Research Council Biostatistics Unit to become one of the directors of the network hubs for trials methodological research for 10 years. One of his main research interests, as he likes to say, is in the design of clinical trials, and he has worked in developing novel adaptive trials design in over 10 years. So he has a lot of experience in the area, and we will be so happy to have you here, Adrian, and thanks to accept the invitation.
Thank you.
Okay, I thought you, well, perfect. Thank you very much, Adrian. Adrian is going to give a talk about designing adaptive clinical trials for combination therapy in type 1 diabetes. Thank you very much, Adrian, and please go ahead.
Thanks. So I'm going to talk about a project called Anodia and about master protocols and how to design various trials. So I'm going to introduce the network, and then I'm going to talk a little bit about the FDA guidelines on master protocols, and then show you how we designed our master protocols, how we designed our trials within that master protocol. So I'm part of a large consortium called Anodia. It was funded by the IMI projects, and we have 31 academic institutions across Europe, 6 FBA partners involved and help fund this, a small SME, and also we get funding from the Juvenile Diabetes Research Fund and the Helmsley Trust. And the idea was to set up a clinical infrastructure to do clinical trials in type 1 diabetes, and to look at obviously omics technologies, as well as doing innovative clinical trial designs. and to set up a network of labs and databases in order to do everything in a very standardized way. So these are some of the sites. There's actually more clinical sites, and this is quite a bit outdated, but we've got a lot of coverage in the UK, Germany, France, Belgium, Finland, and various places. And there's clinical sites, there's hubs that just deal with the samples as well. And the master protocol is something that is relatively new. The FDA have been pushing people to write more master protocols. There's a guidance written about it, but often, like a lot of innovation in trials, it's very specific to cancer trials. And this document is very much about cancer trials, but the idea is that master protocols can do multiple trials within one document. So therefore saving a bit of the infrastructure of setting up different trials all the time. And there's some references there about this. So the benefit of having a single document, the single protocol, is that you'll be able to test multiple drugs in multiple, in their case, cancer subpopulations in a single protocol. And that's called the master protocol. And they've used master protocols often to design large umbrella, basket, and platform trials. These days, a lot of the COVID trials run under a single protocol as well, and also master protocols. And like I said, it's under a single infrastructure. And you have to make sure that the trials are designed well, and to ensure the patient safety traveling through all these trials, and also to get good quality data. So in our case, we try to make all our SOPs standardized across all our clinical centers. There's common study manuals. We had a very standardized version of the mixed meal tolerance test, which is the main test for measurement of the outcome in type 1 diabetes, because they're measuring C-peptide response to a mixed meal. And also they had ways of collecting the information at home as well on dry blood spots. And with this, we had a centralized storage of samples as well as data. So that was important to us, that we had quality data and samples in storage ready for the future. And they are doing like about 7 different omics platforms within this, and doing obviously data exploration around that. So the master protocol is not an easy thing to develop. We were in conversation with a guy, Thorsten Vetter, who's was our scientific officer, to talk about using a standardized protocol for our usage was phase 2 innovative trials, small mechanistic trials, not phase 3. And we went through a long process where you end up writing various documents. They give us questions, we write back, and eventually we had a face-to-face meeting to make sure they would endorse our approach, which we received. So it took us about a year to get endorsement from the EMA. We thought this was important for maintaining the high level of standards, but also to encourage people to use the network to run their trials in it. And the structure of the master protocol is, you have this master protocol which has everything to do with your platform, the infrastructure, harmonization, how you collect data in terms of electronic CRFs and the data warehouse. And then each individual trial can have slightly different objectives, slightly different rationale. You have then the power, the analysis plan, and how you're monitoring safety within those individual protocols. And the master protocol just keeps a list of those trials. In reality, when you're running a trial under a master protocol, those trial protocols will probably be standalone documents. So you cut and paste a lot of the information from the master into the protocol for the clinical sites. So at the moment, we've got 4 trials which are running within the master protocol. And just to show that these sub-trials are all under the same document, but they're all quite different. So we have different age groups, some going into smaller children, some just adults. The treatments have different mechanisms of delivery. So you have infusions, injections, tablets at various different durations. And yeah, so they're all quite different trials, unlike a cancer trial where you might have the same population across multiple sub-trials. So it does increase complexity within this area. So this single platform, you can evaluate multiple treatments, like I just described. We've got those 4 trials, but they also encourage you to investigate treatment combinations and to investigate subgroups. And in type 1 diabetes, it's not maybe as well developed as oncology, so age is our main sort of deriver of a subgroup, but that's why we're collecting all this information in the omics in order to understand whether there are other subgroups that are of interest. Within all of this, they recommend to have a common control, and trials can actually be perpetual as treatments go in and out of the master protocol. And common control was something that the FDA document pushes, and you think about comparing treatments to just the concurrent controls. So you can't start comparing controls to a past trial, which is maybe finished. And like I say, we consider each of the sub-trials as independent trials, so we don't adjust for multiplicity across different sub-trials. But if you did start asking questions, which out of all these treatments across all these sub-trials are good, then you would have to start thinking about controlling your false positive probabilities. The other things about the master protocol is the FDA recommends that you establish the recommended phase 2 dose before you enter a treatment. Within a master protocol, you can do an initial dose finding phase before that. And master protocols can be really exploratory. They can support a marketing application, or they can, do what we're doing, support, investigate multiple parallel drugs. And each sub-trial can be fixed or they can be adaptive. So within our trial, we've got both. But just to show you the platform, this is the underarching platform of what we're measuring. We measure the same things at regular intervals in follow-up. And this is standard across all our trials. So we have the same base for every trial. But when you introduce a new trial, we allow them to add in additional measurements. So for the MELD ATG trial, which I'll describe a little bit, they added in extra visits and extra measurements for various safety measurements and other omics. So you can introduce additional measurements on top of our platform. I've said that already. So we've done 2 novel trial designs. There's a trial with verapamil, and this is a 2-arm parallel group trial in adults. And we used longitudinal data within that on C-peptide response, and we did an interim analysis, kind of about a third of the way through to make a decision to stop or not, which I'll go in more detail in the next few slides. The MELD ATG trial is essentially, ATG was a treatment that's already given some evidence in type 1 diabetes, and we're looking at trying to reduce the dose as we go into younger people, because it has some sort of reactions within the first few days of administration, but it is a single injection. So that's quite a complicated Bayesian adaptive design in order to find the right dose. But the verapamil study, which we call VERA-T1D, like I said, has this interim. We always tend to randomize more to treatment than placebo, so a 2-to-1 ratio, and we have an interim analysis. Essentially, we have C-peptide measured every 3 months. Our primary endpoint is at 12 months, and our interim is planned at 10 months. And you kind of think, well, we don't have much information, but we obviously see some information at 3 months, 6 months, and 9 months. And we did some simulation work that says that we could do this interim at 10 months, assuming that recruitment is around 5 per month. And we did this sort of simulation work in order to say this would give us a reasonable answer to stop if verapamil isn't working. And our decision criteria is the standard statistical methodology, is a longitudinal data analysis model. We look at a Z statistic. If that's less than minus 0.5, which means that verapamil is doing slightly worse than placebo, then we'd stop for futility. Otherwise, we'd continue. And that gives you various benefits. So there isn't a great chance of stopping early, but if verapamil is the same as placebo, it gives us 30% chance. But that still gives us an average saving of 23 people. And the reduction in power about doing this futility is only about 4%. So it's worth doing. I'm not going to go into the detail of the model, but that interesting decision making at the interim is where we wanted to start triggering combination arms. So obviously the intention of the platform trials is to investigate combination treatments. And so we've been looking at different combinations with verapamil. This VERA-T1D study is still ongoing. We're probably about 10 months into recruitment. Because of COVID, it's not gone as fast as we'd hoped. But we wanted to use that interim analysis to trigger a combination trial. And so we're saying that if verapamil is actually slightly better than placebo at the interim, we will trigger a different trial to begin, which is called what we're calling Vera Plus. And the combination will use verapamil in every combination, but either combined with depleting agents, which have shown some evidence in type 1 diabetes, or blocking agents. And that was our shopping list of different agents that we went looking for. But the trial design is this. So we have the original Vera T1D trial, which is a 2-arm trial. It's double blind, verapamil versus placebo. And we're going to introduce early next year this combination arms. And essentially every combination has a different way of administration. Verapamil is a tablet, but some of the others are injections. So we wanted to make the combination arms open label. We're going to start with verapamil versus abatacept plus verapamil as a combination. We're going to have the same entry criteria for the combination study as the original study, the same age group, everything is going to be the same. So essentially, we're going to have people who can consent for both trials, where they're going to randomize them to either trial, and then you randomize them to one of the arms within the trial. Hence, we can compare this new verapamil plus trial with the old Vera T1D trial. And so therefore, we don't need to have another placebo group in the Vera Plus arm, because we have that information from the previous study. So we'll have, this is a very quick way of trying to look at whether combinations show any benefit over monotherapy. We are not going, you'd need large numbers if you wanted to prove that there was an interaction, and that's way too large for our populations and our budgets. So this is, even if there's an additive effect of 2 treatments, we should be able to detect it, and that should then spur us on to later phase 3 type studies. And the last combination trial I want to talk about is maybe an even more radical decision, but there's an investigator from Norway called Knut. They did a trial in type 1 diabetes called DIVID, and that's just about reporting at the moment. And then he wants to take one of the treatments from that and combine it with lots of other different ways to do interventions. And he's particularly interested in, obviously, the closed loop insulin pump therapy, antivirals, anti-inflammatory, or to supporting beta cells through fenofibrate or a healthy diet, ensuring vitamins and antioxidants. So you've got 4 interventions there, and we discussed things. He's been to the Norwegian ethics committees or regulators, yes, or Norwegian regulators, and they've agreed that we can put all 4 together in an intervention. So our idea for this trial is that we want to pilot a non-randomized pilot in a very small number, like 20, and we're going to pilot all 4 treatments together at one, because that'll show the largest benefit if if there is a benefit of all 4. And then if that shows promise in the single arm trial, we'll then randomize to either all 4 or removing one each of the elements. And the fact that we can do this means that we should be able to detect which of the components has the largest impact, and should sort of maximize patient benefit. I think the other way to do things is obviously start in monotherapies and adding combinations, but you'd have 4 monotherapies plus combinations. It starts getting a lot of arms. So we thought this would be the easiest way of trying to find what the main effects are of each of the treatments. I've done various power calculations for this, and it all seems to be in the realms of 164 people in the randomized phase, which it should be practical and feasible for a reasonably large difference of 0.22 in the area under the curve C-peptide. So in conclusion, I just want to say that master protocols are difficult to write, complex, but they actually lead to great operational efficiencies. We had one of those trials, the IMPACT trial. They, from idea in their head to starting dosing treatment of people, it took 9 months because they had the master protocol. They went through ethics committees very quickly. So once we got it in place, it means that things should move very quickly. So the master protocols also help us standardize everything, which means that we have a huge data resource across multiple trials that are comparable and well known and should lead to greater learnings in the future. And like I said, you can have shared controls, but we also have a natural history study underlying the platform. So the people who don't enter trials, they enter a natural history study. So this obviously is used to understand biomarkers, etc. But they're also a huge resource into being an additional control group for our inference in our trials. And just to say that the combination phase where we can add combination arms in and out of an adaptive trial means that we can do things relatively efficiently, and it's driving type 1 diabetes forward quickly, whereas I think there's not many combination studies in type 1 diabetes. So that's the end of my talk.
Thank you very much, Adrian. This is a fantastic talk. I think we have learned a lot about these master protocols. So, see, a lot. So let's, if Christina and Bram, can you join us? So we will start the questions, open the session. Okay, thank you very much. I have to tell you that we have many, many questions, almost 20 questions. I'm sure that we are not going to have time to cover all of them. So I'm glad to receive these many questions because you have raised a lot of interest in the audience. Let me select a couple of questions for each of one, trying to be a short answer because I would like to start the second block on times that we have almost 7 minutes. Okay, something like this. Let me start by order. Christina, I will start with you. One of the questions that we have for you is one of the attenders is asking you, are the difference in diagnostic patients across Europe? Are there difference in diagnostic practice across Europe? And is there an association with patients' outcomes based on this practice?
So thank you for this interesting question. The answer is definitely yes. There are clear differences across countries, and this is something that patients' associations are really struggled with. So we are receiving sometimes patients from other countries arriving to us to have that opportunity. And the second part of the question, it was?
And if this difference in the practice have any impact in the outcome of the patients?
So it's difficult to measure, definitely, also because we don't have clear statistics about that. In each country, the access to different drugs are through different ways. We have some expanded access programs in some countries. We have clinical trials. So unfortunately, it's not a clear way to measure that.
Another question for you, Christina. Great talk is saying the attendant. In oncology, what is the preference? Combination therapy given at the same time versus a stepwise approach to combination therapy? So, what is the preference?
Again, this is a great question. So in metastatic breast cancer, we have a final goal that it's improve the survival of patients. So it depends on the moment. So mainly we have clear answer from clinical trials saying that the sequence it's better than the combination therapies because there is no an overall survival benefit when you use combined therapies. So we try to have a strategy to have patients living longer and with best quality of life, because as you all are aware of, when we use combination therapy, sometimes the toxicities are overlapping, and this is something that we have to deal with. So for patients that are not on visceral crisis, that it's an urgent need for a quick response in our field, we use sequencing, and the only situation when we use in metastatic breast cancer the combination therapies are in that urgent situations that we need a quick response. In the curable setting, this is different, and we use the best treatment. And for example, in HER2-positive breast cancer, we use a combination therapy with 2 antibodies because we know that that strategy could improve pathological complete response, and this is very well established that increase event-free survival and overall survival. So it's kind of different, the strategy. In early setting, a curable setting, we use combination therapies when needed, and in metastatic setting, we tend to sequence therapies, trying to have better quality of life.
Agree with you. Yes. A quick comment, Cristina. How do you manage to make affordable this pre-screening strategy at your institution, at Vall d'Hebron Hospital? How do you manage? So
we've been dealing with that since 2009, and we had different strategies over time. Now I would say that we have a win-win strategy in collaboration with the industry. We have our own pre-screening program, and we try to have different models of collaborations with the industry and the companies, trying to offer them kind of different models of collaboration, of course, with different economic collaborations. So if they are interested, for example, into finding patients with a very selected and very uncommon alteration, they are not paying for, let's say, 1,000 of patients. They are contributing to our screening program, and we are contributing to the trials with the patients with that specific alteration. But the program, it's now receiving money from different companies, and it's easier for them because they can find more patients with the specific alteration, more than the patient that they are paying for. And we are having those different collaborations, and that permits us to include patients in different trials with very uncommon alterations. For example, in breast cancer, patients with HER2 mutations, that it's not amplification, mutations, are around 4% of the patients, and we are one of the sites in Europe recruiting more patients with these very uncommon alterations. But we do have very active treatments, and this is kind of a strategy built on different models of collaboration. But at the end of the day, each company arrives to us, they want patients with specific alteration, and we try to work with them to build different models. I have these models here, and if you have that specific interest, I can share with you the details.
Okay, Cristina, thank you very much for your explanation. Let's move to a couple of questions for Bram. Bram, here is a question for you. One of the attendants is saying, tofacitinib is approved treatment for ulcerative colitis, but phase 2 trials in Crohn's disease was negative. What is the explanation of this?
Well, that's a good question. So I think that there are various things to say about that. I think first of all, the way at the time of the tofacitinib study in Crohn's was designed was different than it would have been done today, I would say, right? So we know that there is not a perfect match between symptoms and endoscopic findings or other objective markers of inflammation in patients with IBD, especially in Crohn's disease. So, and at the time, in many studies, the inclusion criteria were mainly based on clinical symptoms, and there was no yet a requirement to have endoscopic proven disease activity. So that might be one of the explanations. I think that there are various other explanations as well. The chances, I think, that it would be taken up again and investigated further in Crohn's with what we know today, I think are very limited, because there is an entirely, there are many different JAK1 selective blockers coming onto the market also in Crohn's disease. There are many more selective other JAK inhibitors being developed for Crohn's, for rheumatoid diseases. So presumably, I think yeah, I would say tofacitinib will go primarily for UC, and it will not be reinvestigated, I think, for Crohn's disease.
Thank you. There is another question. Very nice presentation. It's starting. At this ask and see. Combining two biologics at induction is very fascinating. Okay, he's saying, but primary non-responders risk to lose two mechanisms of actions at once, right?
Yeah.
What do you think about it? What do you think about it?
I agree. So, and that's why I really like the conclusion of Christina as well, where she said there is no such thing as one size fits all. And that's why I think we need to aim, instead of just starting a trial recruiting patients randomly, I would say we should be much more smart and dive into the molecular phenotype and then match the combinations, because I do believe that in some patients, if the inflammatory burden is very, very high, that we can achieve more and that we can achieve deeper remission more quickly if we combine at the start various inflammatory cascades, so that chances of, I would say, alternative routes which are then might be switched on, that we try to dampen that as much as possible to bring the patient into remission as soon as possible. But I fully agree indeed that if you start two biologics at a time and the patient is not responding, yeah, that we burn, let's say, two lines of therapies. And that's one of the things which is still an open question. This is not just for combinations, but the sequence of therapies is also very fascinating, and we basically don't know a lot. It might well be that a patient now is not responding, for instance, to anti-TNF, but during the disease course, the biology is also changing. So IBD is not something static, it's very dynamic. There is influence of environmental factors, there is influence of previous therapies, but there is a lot on the molecular side we still don't know. So there are many questions to be answered still in future.
Very briefly, because there are many questions, it's a pity don't have time to explain to us, all of you, very briefly, if you can comment on this. Are gut microbiome profiles monitored in patients before and after to see response to immunomodulatory drugs? Is this an opportunity to select patients and monitor response? Microbiome profiles?
It might be. The question will be, is this drug specific or is this a surrogate of the inflammation? So I think these are two different things, and that's one of the routes, I think, or the ways people are trying to distinguish and discriminate responders from non-responders. Yes, also in our institute.
Thank you very much. Let's move on to you, Adrian. There are also many questions. I will select a couple, if we have time, a third one. One attender is saying, for the combination trials you described, what is the role or potential promise or risk of using surrogate biomarkers of response to accelerate signals in this trial? Is this just too complex, given an incremental benefit, or is it something we need to consider as we develop disease and response biomarkers?
Response biomarkers. Yeah. So within our trials, we've got the primary outcome is C-peptide response due to a challenge. That is a component of what the regulators will accept. The EMA is slightly different to the FDA. In terms of other biomarkers, we're measuring C-peptide at home. There's like a self-administered, it's not exactly a mixed meal tolerance test, but they are taking a challenge on in fasted state. They're taking blood pricks at 0 minutes and then 60 minutes later, and these are sent in dried, air dried, and you can get C-peptide measurements at home. So we are collecting lots of information. I think in terms of the perfect endpoints for type 1 diabetes, there's still a debate. So we are collecting everything. We won't have enough power to detect some of the clinical endpoints that are binary, because you need large numbers when you start thinking about time to an event or time to avoiding side effects. You need much larger numbers than we're looking at, because we're in the phase 2 realm. But in terms of continuous biomarkers, we are measuring a lot. Retrospectively, we'll be thinking, next time we should have used these endpoints. But C-peptide is a reasonably established endpoint. So.
Another question, Adrian. In programs designed to evaluate novel combinations of 2 or more investigational drugs, where the safety of the combination regimen has not been established, how we can manage to ensure patient safety? I think this is the main concern. Yes.
Yeah, that's great. And you know, in terms of the last study that we talked about, I was surprised that the Norwegian regulators would allow you to go in with a quadruple combination from day one. But obviously, with all these trials, you have safety. We're looking at combinations of drugs that have already gone through different phases, and they have some evidence in type 1 diabetes. So there is a safety profile on monotherapies. And then with a combination, obviously, you are going to be looking at signals. People aren't, you know, if there's obviously any signal, you wouldn't put two drugs together. But if there was a safety signal, we have data monitoring committees. We have, you know, we report to the same high standards as, say, oncology trials. We have all AEs reported through the CTCA systems. So we'll be looking at that data in real time. And then if anything, any signal comes up, we'll be detecting it and reporting. So it's we're not in a phase 1 situation where, you know, safety is the primary. We're assuming some of the, you know, the combination shouldn't induce something that is more toxic than each of the drugs, because they're not particularly toxic, the ones we're looking at. So use the usual monitoring.
There are many questions. Several attenders want to know the difference between umbrella trials, platform trials, and basket trials.
Okay. Very simply.
Very briefly.
So if we take oncology, a basket trial is where you might look at lung cancer, ovary cancer, you know, different types of cancers, but you're looking at the same genetic mutation that might be the causal mutation, and you're targeting a single treatment to across those different diseases. Now, I didn't say in type 1 diabetes what that might be, but obviously you have a collection of autoimmune diseases that you could put together, and they might have the same mechanism of action. You might have different endpoints, but you could look at efficacy across multiple things. I think that was also mentioned. In terms of a platform trial is where it's a bit of everything. You can look at subgroups, you can look at lots of different treatments. Treatments can be added and taken away, but it's a much more complicated, large platform. So the umbrella trial is where you're looking in oncology now. You're looking at one single disease area, like say lung cancer, and you're looking at multiple different genetic mutations and treatments that are linked to those mutations. So in one study, you might have this drug on that mutation, another drug on that mutation. So they're targeted therapies, but under one document, so you save a little bit of logistics. And therefore, you know, like lung map, you're going to take a blood sample, you're going to do lots of biomarkers, and then you'll be able to see who can go into which part of that trial. So it's a much more efficient way than trying to target, I've got a trial that targets this biomarker, and then you go searching for it, because obviously screening is going to be wasteful. So if you do it all together, it's going to be efficient.
Okay. Thank you very much. We do not have more time to answer more questions. I have to tell you there are many more. Most of them are giving all of you congratulations for your excellent talks to all of you. So I repeat these congratulations in behalf of the organizer. Thank you very much for staying here. And it has been a great pleasure, honestly. Thank you very much.
Thank you.
So thanks.
Bye.
So let's just stop 3 minutes, because we have to start the next block. Now it's 34, just 3 minutes, let's say. We are going to start at, now it's 34, in 3 minutes, 37. We are going to start the second block, and you could have a small bio break, and we come back in 3 minutes with the second block of presentations. Thank you very much to all of you. See you in 3 minutes.
So welcome back. My name is Toni Julià, and I'm the head of the Rheumatology Research Group at Vall d'Hebron Research Institute in Barcelona, as well as Chief Data Scientist at Imidomics. We will start now with the second block of presentation, translational challenges in combination therapies. Before we start back, just remember that if you have any questions, use the tab to put those questions, and we will forward that to the speakers at the end of the three talks. Let's start with our first speaker. Today we have the honor of having Julio Sáez present his work. Julio is both full professor of medical bioinformatics and data analysis. He's also the director of the Institute of Computational Medicine at the Faculty of Medicine at Heidelberg University. He's also a group leader in the Molecular Medicine Partnership Unit between Heidelberg University Hospital and the EMBL. And finally, he's also co-director of the DREAM Challenge. His contributions to the advance in precision medicine are really inspirational. We're really thrilled to have him here today. Julio will talk today about combining high throughput perturbation experiments and mathematical modeling to identify efficacious combinations. So Julio, the floor is yours.
Thanks so much, Tony, for the kind introduction. Do you hear me well and you see my slides?
Yes, perfect.
Very good. So yeah, it's great to be here in this very exciting workshop and be able to share with you some of our work. So like many in this symposium and building on things we've heard before, we are interested in how we can use different large-scale molecular data to better assign drug and drug combinations to treat patients. By large molecular data, I mean omics data, proteomic, transcriptomic, and so on. Data that we can collect across different samples, let's say patients, and also that we can increasingly collect at the single cell level or even with a spatial resolution, even though today I will not go into that. It's an area that we are very interested in. And that also can go beyond looking at what is the molecular profile of the patients, but also the microbiome. And as we heard in the beautiful talk just before, this is also a very important aspect. So the way to try to use this data for improve the treatment, or one very natural approach, is try to input this into a statistical or machine learning model, and then with these models extract either key features that are the predictors that are potential biomarkers of disease or of treatment efficacy, and also use algorithms to predict the effect of new therapies. And we will hear actually afterwards a very exciting work on the use of advanced machine learning. And we are also using some of these tools, but what we are mostly focusing on is in how to help machine learning with things that we know from biology, things that are available in literature and databases around the underlying molecular mechanisms. And the reason that we try to support machine learning with this strategy is that we have a lot of features to deal in our models. So, but instead of having to look at all the genes or all the proteins at the same time, by extracting the effect of particular processes, such as whether pathways or transcription factor or other molecular processes, we are integrating and simplifying the number of things we need to look at. So we increase the power of our statistical analysis, and also this biological knowledge allow us to improve a lot the understanding of the results of machine learning models. And for this, we are developing over the years a number of tools. All our tools are free, open source, available on our website. For example, means to access biological knowledge from different databases in the public domain. So we have an integration of those in something called Omnipath, which is around now over 100 different databases all available in one place. We also develop different strategies to extract those mechanistic features I was mentioning before from omics data, such as activity of pathways, transcription factors, cell-cell interactions, something very exciting in single-cell RNA data, and so forth. And if one uses these features to help machine learning, it is true that they help us a lot. So they really facilitate the analysis of the data and to get stronger models and to get more understandable results. But at the same time, it is true there is still a lot of room for improvement. if we take omics data, profile of patients, and try to use it to predict drug efficacy, drug combination. So this is something that we have found not just in our own research, but also when we use this crowdsourcing in the context of the DREAM initiatives. As Tony mentioned before, we're involved in something called the DREAM Challenge, where what we do is rather than trying to solve the problems by ourselves, we put in the public domain in a way that anyone can try to solve this problem. And we did apply this strategy to drug combinations in the context of cancer. So what we did is to make the characterization of a large number of cancer cell lines. On the right, you see all the molecular features that we have, like expression, mutation, and so forth. And then people were able to use, again, pathways. And then we had data set from AstraZeneca on a large drug combination screen on those cell lines. And then we gave to people a large part of the data, and we asked them, can you predict the rest of the data? And when we did this, we had actually over 160 teams involved, so from all the world. They all try different algorithms, and then this allows us to really better understand what are the best ways to use machine learning to predict drug combination from omics data. And again, as I said before, the use of biological knowledge like pathways is very helpful. And you know, there are different algorithms that work better than others. But also we found that, for example, here on the left, you see the different methods that people try, and here how well they did. The details don't matter too much, but what we really find out is that even though some drug combinations are easy or relatively easy to predict, there were many combinations that were really hard to predict, and no method were able to solve them. And what this also led us to think is to really try hard to understand why it's so difficult to predict drug response in this case, drug combinations. And there are many angles to this. There are different questions around the type of data. There is sorry, my son came. So we found that it's really hard to predict drug combinations. And one aspect that is important to realize is that we are trying to predict the effect of a drug, which is a strong perturbation. In this case, was in a cancer cell, by using basal data, basically profiling of the patients in a resting state. And you can think that this is, of course, complicated. You're trying to predict the effect of a perturbation from something basal. One thing that I really like to try to make this point, this is from a review from Tony Latai, an oncologist in Boston. And he says, consider trying to predict what happens if you poke a dog with a stick. So analogy to what we are now describing here in this prediction with molecular profiles will be like to kill the dog, make a lot of omics on a lot of the aspects on this animal, and then try to use all that information to predict whether the drug is going to work or not. And then he says, well, the alternative functional approach is simply hit the dog with a stick and see what happens. No? So this idea that to understand how drugs affect cells, it's important to have data on how drugs indeed affect cells, not just the basal data. And so for these reasons, we are very interested in complementing the use of machine learning with a more dynamic approaches where you perturb cells, you see how it responds to perturbations, and you use this to build very detailed mechanistic models of how cells respond dynamically over time to being exposed to drugs, but also to stimulation with different ligands. And for this, we have also a number of tools. I will not go into details, but the basic idea is that you combine, again, the biological knowledge from different resources with how the cells respond to different perturbations. And you build this together into something that's called logic model, which tries to draw an analogy to electrical circuits, and you try to describe the processes inside the cell as if it were an electrical circuit with different gates, and uses to try to explain, in this case, the molecular response of cells to different perturbations. And then the idea is, can we use these models to help us to better answer this question of which drug will be, or which drug combination will be efficacious in which patient, and can we predict the effect of new drug combinations, and does this have an added value over predicting purely from the basal in a more direct statistical manner? So then we had applied this first in the context of the cell lines. I showed you before these cell lines where you have many omics data, and then you have drug either monotherapy or drug combinations. So what we did is to focus on particular cases where we could not simply with machine learning predict the efficacy of drugs, and we do a deep dive where we take the cells, we stimulate them with drugs and ligands, we measure the changes in key proteins using phosphoproteomic technologies, and then we use this data with this idea of the logic models to build for each, in this case, in each cell line, from a general network of potential pathways, together with this cell line specific data to build cell line specific models, and then use them to find biomarkers and to really come up with new drug combinations that we could validate experimentally. And we did this in colon cancer first using Luminex technology, and then in breast cancer more recently using single cell proteomic technology. But this is already interesting as a proof of concept of the idea that really perturbing cells and modeling mathematically the effects can be quite helpful. But this is limited in you want to apply to patients, because in the case of patients, you don't have as much material, right? So if you want to do these perturbation studies, you need to take cells and under different conditions, perturb them with drugs, see how they respond, and so on. And this is perhaps in blood possible, but otherwise from a patient, you don't have enough material to do this. So for this reason, we work closely with the group of Christoph Merten, who was here at EMBL Heidelberg, now in Lausanne at EPFL, and clinicians in Aachen, Thorsten Kramer and Ulf Neumann. And we develop a strategy based on microfluidics to perform drug perturbations ex vivo. So the idea is like a sketch here in the bottom. You can encapsulate in a small droplet cells with drugs and some barcodes to know in which droplet which drug you put, and then monitor the effect of the drugs in the cells. In the first work that we published a couple of years ago, we used a very simple caspase reporter. This was to see if we're killing the cancer cells, but now this is coupled with single cell RNA, so we can measure after perturbation the changes in RNA. And then what this allows us is to perform really from a small resection, in this case from tumor biopsy, but we are now applying it also to other diseases, to perform like a miniaturized perturbation drug combination experiment. And then we can also use this data to build mathematical models. So for each patient, we have dedicated perturbation data with this caspase reporter. We have general knowledge of the different pathways. So again, as before with the cell lines, we can build a mathematical model which is specific to each patient. And this is just to give you an example or an idea of what these models look like. So this is the underlying model. So these are the different pathways that we include, the different proteins. And we are able then with this model to really look at the differences across the different patients. So we can see, for example, at the level of NF-kappa B, whether this is functional, meaning whether this is dynamically active in which of the patients, and these little boxes on each of the proteins simply shows how some proteins are active and some are not in the others. And then what we are also able to do, because this is a model that simulates how the cell responds to treatment, we can simulate the effect of new perturbations. So what happens now if I take different drug combinations and drug combinations for which I have no data? So I have not generated this data, but with the model I can try to predict them. And we did so, and we were able to validate this in cell lines and in vivo mouse models that in fact these new drug combinations that were predicted by the model are then efficacious, either in vitro or in vivo. I mean, of course, in this case, the ideal scenario would be not just to do it in the cell lines or in the mouse model, but really if you have the model built for a particular patient, to go back to that real patient, so to the person that from which you take the resection and from which you build this model and try to test it there. And this is, of course, something that has to be done very careful and with all the approvals in place. But we are in the process of launching a trial, and this is just one example from a patient in Aachen in the clinic, Ulf Neumann, that he had a tumor of unknown origin, and the first line of treatment combinations did not work out. Then a resection of the tumor was taken using this strategy. Different combinations were tested. And there was here as a candidate a combination of cisplatin and gemcitabine. And then when this drug was given to the patient that had here, as you see, the a very active tumor, the treatment was able to significantly decrease its size. Unfortunately, this didn't last very long, so the tumor developed resistance, as is often the case, and eventually the patient died, but at least it was, we think, a promising preliminary result. Because, so just to emphasize, the idea of this approach is that because you only need a very small amount of material, and you can do the experiments very fast, you don't need to grow them, anything, you take the cells, and really within hours you have the data. Potentially something that you can really have in the hospital and have it as a additional evidence. Of course, you have to think of other molecular markers, in this case of cancer mutations and so forth. But this functional response to drugs, we think, can be quite powerful to inform treatment of patients. And just as you may have noticed, all I talked was about cancer. This is, of course, because, yeah, that's where many of the things in precision medicine are more advanced. It was also said in the previous talk, and also where there is, more data. But these approaches are really applicable to other contexts. So we have worked in the past in multiple sclerosis as an autoimmune disease. We also have some other projects on kidney immune diseases. And just to illustrate that the same idea can be applied out of cancer, this is a study we published recently, although it's a project that took a number of years. But so this year, so Marty Bernardo, a former postdoc in the lab, what he did in the context of a European project with people in the clinic hospital like Pablo Villoslada and others, is that we got access to blood samples from multiple sclerosis patients. We follow the same idea. As I told you before, in the case of blood, it's one where you can really get enough material to do perturbations studies. So we did, let's say, more standard approach of stimulating these cells with different ligands and with different drugs for 150 donors coming from different places in Europe. Use this approach to build the models. So from a generic knowledge of pathways and so on, and the spacing-specific data, we can derive some donor-specific models of the underlying pathways that we use to predict combination therapies. And again, this is on the left, the network of the different processes that were involved. It's a bit light to see, but some of the components of the pathways we saw that were present in multiple sclerosis, some were present only in healthy patients, and others were in both. And Marty developed a computational strategy. I will skip the details, but really tries to find which of the things that are different from multiple sclerosis and healthy could be targeted and modulate the effect of a given therapy, because we knew how these patients respond to some standard treatments like fingolimod. And then he came up with a particular combination of this fingolimod and attack inhibitor, and then using a mouse model, we saw, and of course, this is just a mouse model and much more work should be done, but as a proof of concept that this combination therapy that the model derived from the analysis of this signaling network, it was more effective than the individual drugs when treating this mouse model. And with that, I like to finish. First, I'd like to thank the people in the lab who did the work I showed you, and we have a large number of collaborators, both experimental groups, like the work, as I said, multiple sclerosis, was with Pablo Villoslada, and the project in oncology, as I said, with the clinicians in Aachen. We always have open positions. I have conflicts of interest from funding from GSK and Sanofi, and fees from Travere. And just the last minute or so, I would like simply to summarize what I was trying to tell you. So how machine learning is a very strong technology. And again, in the next talk, we'll hear even more about that. But how we think that there is work to be done to apply it effectively in personalized medicine. And in this context, the use of biological knowledge can be very helpful. And I spent most of my talk talking about a different way to try to look at personalized medicine by perturbing cells and building dynamic models and using these models. And in general, the approach we follow then is that from databases and other sources of knowledge in the literature, we built a general model, right? Because the databases are typically not specific for a particular disease, and certainly not specific for a given patient, but taking the generic knowledge and modulating this with patient-specific data, be some aesthetic molecular profile or be dynamic response to perturbations, we can build these patient-specific mechanistic models, which then in turn we can interrogate to get better understanding of what's happening, but also they can help us to predict the efficacy, the potential combination therapies. Yeah, thank you for listening, and I look forward to your questions.
Thank you very much, Julio. Impressive talk, as usual. This technology you're developing is incredible. It's totally at the forefront. Congratulations. So let's move to our next speaker. It is a pleasure for me today to welcome Mohammad Lotfolahi. Mo is a third-year PhD candidate in computational biology at the School of Life Sciences in the Technical University of Munich under the supervision of Professor Fabian Theis. His work has focused on leveraging single-cell technology and machine learning for biomedicine and drug discovery. He's the developer of SCGene, a tool to analyze and predict the effects of perturbations like drugs or diseases at the single-cell resolution. He has also developed SCArches, a tool that leverages transfer learning to create, share, and integrate new datasets into existing references. Apart from academic research, he has also participating consulting from drug discovery companies, and he's actually collaborating with Facebook AI around machine learning for health. Mo will be presenting us today leveraging multimodal single-cell atlases to predict perturbations. So Mo, thank you very much for sharing your research today, and the floor is yours.
Can you hear me?
Yes, we cannot see you though.
All right, I just tried to share my screen. I think something is going wrong, but like, okay. Do you see my screen?
Yes. Good. Yes.
Unfortunately, I cannot hear you for some reason.
We can see you now. We can hear you well.
Sorry, I think I have some problem with the connection. Okay, cool. I just saw that we can hear me. Okay, cool. Thanks a lot. For the introduction, I'll talk about general single-cell perturbation modeling. I think Julio already set the ground for this, and single-cell analysis have built and also made a enormous progress during 5 years, last 5 years, and then today we are dealing with a large cohort of data sets that we can actually use for analyzing disease trajectories, and the size of such data sets gets bigger and bigger. Now, so basically the chart that you see, it belongs to 2017, but like the whole journey started from 2009, where we had like only 9 cells for the first single cell experiment, and now 2017 was like 1.3 million cells, but by now it's close to 5 million cells. So basically the latest data set from Cole Trappin lab, it's 5 million cells. And then with this amount of data, you always need scalable algorithms, and machine learning always is a top candidate for that. And the other challenge with single cell analysis is like again, it's a super fast growing field, and we started from gene expression, but like the advances now enable to analyze and basically extract different information from a single cell. And the ultimate goal is to integrate all these data sets using machine learning or like other methods, but again, since the scalability requires, we need scalable algorithms, so machine learning is a good candidate to build multimodal reference atlases. So by incorporating all these data modalities, we can, okay, so I see that we cannot, okay, I think you're not seeing my slide transitions. Okay, it's frozen on the first slide. Okay, so maybe I start sharing again. Can you see my slides now? Okay, sorry. Yeah, so basically, as I said, now we're dealing to basically build multimodal reference atlases using machine learning. And a challenge here is how to make these reference atlases usable, because once you've integrated data, now you have to make them usable. And then once you have this reference atlases usable and like people can actually leverage those and then train models, you can answer multiple questions like what are the genes or what are the genes that has been perturbed or changed before and after a certain treatment? What are the gene programs that have changed, or what cell communications has changed? And the most important question, which I would focus for this talk, is about predicting effect of drugs at single cell level. So perturbation biology for single cell genomics has evolved, and the ultimate goal is to build a basically perturbation reference atlas where we have a lot of cells from multiple studies, could be also from patients, before and after treatment with certain drug, or like before disease and after disease, and also treated. So once we have this reference atlases, we could answer to multiple questions. So those questions are, what is the effect of a certain drug on gene expression, on a cell type that you haven't measured, or phenotypic measurements like what are the drug efficacy or the response of a certain drug at single cell level, or target and mechanism prediction, or also for combinatorial prediction. So if you have genetic knockouts or double knockouts, how are they interacting with each other? And finally, chemical property prediction. What are the chemical properties of a certain drug that would induce certain cell behavior at single cell level? To address these problems, the first approach that we took was we took an approach inspired by computer vision and machine learning, where people actually showed that if you learn a deep learning model based on images of man with glass, and then images of man without glass, and then you have images from woman without glass, and you do simple arithmetic, but not in the image space, rather than in a latent space where you actually compress the data, you can predict or manipulate images. So basically, and by doing simple arithmetics, you can predict the image of a woman with glass. And we saw that can we do this also on cells and single cells to answer questions like, can we predict the perturbation effect of a cell type given the observed effect in other cell types? So by just doing simple arithmetics, or we can go higher and then like predict effect on between species. Can we learn based on one species and go and translate the effect on another species? This was the first effort that we did back in 2019, where we actually designed the model called STGen, so single cell generator, where we follow the same idea that we encode the gene expression for the training data into a latent space. So we learn a generative latent space. And in that latent space, we estimate the difference between control or like disease and then treated by extracting this delta vector, which encodes the difference between the control and treated, and add this vector to the cell type that you haven't observed after that treatment or after that perturbation. So once you have this estimated and predicted cells in the latent space, you can blow them up into the gene expression space and have real in silico generated cells for the drugs that you haven't measured in your real experiment. And so basically, this has a nice definition in machine learning. It's called out of distribution prediction, meaning that you predict something that you haven't measured or you haven't seen in your training data distribution. Yeah. So the method is available on GitHub. I'll show you one example, like how this could help and why is it interesting. Is like we applied the model on a population of single cells before and after from 4 different patients, before and after stimulation with interferon beta. So interferon beta stimulation usually causes global responses of like all interferon signaling in different cell types, but it also could cause cell type specific responses, which might be more relevant. I mean, if, for example, if you want to design a drug find a drug which is specific to a specific cancer, then you actually have to be able to model like such specificities. So here in this violin plot, you see different cell types, so B cells, CD4 T cells, and like NK cells, all different cell types. And the genes that you see in the column, they are basically top differentially expressive genes, but at basically most cell type specific ones. So they're not just the genes that express after interferon signaling in all cell types, but they're rather specific to specific populations. And what you see at the bottom, C means control, PS mean predicted stimulated, and RS mean real stimulated. So every time we held out the population, a cell type in the training data, and we tried to predict the effect of that cell type. And basically the model predicted that for some cells and some cell type at single cell level, it has to up or down regulate a certain gene and also leave other genes as they are. So basically it finds out responsive and non-responsive genes after the perturbation. And this is basically the magic of nonlinearity of deep learning. We apply the same thing with using PCA, so basically simply doing linear arithmetic and those addition and subtractions at linear space. What we found out in this box plot is like, in this box plot you see 10 bins, and each bin basically shows the prediction of 50 differentially expressed, and the genes go from left to right. They go from most cell type specific genes toward global responses that happens everywhere. And if you look at the y-axis, which shows the error between the nonlinear and the linear method, you could see that the biggest difference comes from the most cell type specific genes, where the nonlinear model, the deep learning model, outperformed the linear model. So this was our first effort to model single cell perturbations, and obviously this and this becomes really important if you have combinatorial treatment. And unfortunately, the previous model was not possible to predict the drug combinations with the previous model. And then obviously the model was also a bit black box in a sense that you couldn't get any interpretability. And to address those challenges, we combined ideas from linear models with deep learning to come up with an interpretable model. and also model different aspects from the perturbation data. I mean, basically a perturbation experiment that you would get in single cell, such as patient level or cell type level or dose and time. This is the work that we did together at my internship at Facebook AI, and then later a collaboration between Helmholtz Center and Facebook AI. And here's a basically a fun movie about like how this model works. So the model actually learns to disentangle the perturbation effects and covariance effects from the cell by encoding it into a low dimensional representation to bridge to the basal state, which is free of these variation. And it actually learns to add back these effects and then predict the gene expression response. Once you train this model, you could ask counterfactuals, such as, if I have cell A at single cell level perturbed with drug combination A and B, and now you have cell B perturbed with like a cocktail of 3 drugs, could you predict what would be the effect of those 3, so basically the triple cocktail on the cell A, yeah? While you haven't measured those 3 drugs at on cell A. So here's a closer look at the architecture, and you could see that basically we have the encoder and the decoder. So encoder encodes the gene expression into a basal state, and this basal state goes to 2 what they are called as discriminators. So those discriminators try to remove the information that correlates with perturbation or covariate effects. And then we learn a composition in the latent space by adding this basal state and all the covariates, but scaled with a nonlinear continuous encoder. So this continuous encoder learns dose-specific or time-specific responses for each drug. So everything gets combined in this latent space, and you can basically predict the gene expression for the unseen combinations. And since we also model dose and time response at single cell level, you could have dose and time response per single cell level, basically for all the dosages you haven't seen, because we could actually explicitly model that. And since we learn all these embeddings, that for each perturbation, we learn a representation that you can actually visualize and see which perturbations were similar in terms of response on gene expression. And then and I'll show you like one example how this works. Also in the covariate space, if you have 2 different patients, are they responding similarly to a certain drug or not? So to basically test our method, we applied it on a highly multiplex experiment from Cole Trapnell lab, where they actually tested 188 drugs at single cell level on 3 different cancer cell lines with 4 different dosages. And then basically the output of this experiment were close to like 500,000 cells, and in like 4,500 unique conditions. So this is a huge data, and then like it's really hard to understand this data without having scalable methods. So we applied our model, and since this is basically the cell line latent space, so we actually learned 1 covariate for each cell line, and since these cell lines were super different from each other, the representation that you see there, they're basically, I mean, if the angles were closer, that could show basically these cell lines were similar, but they're not, because they're 2 different cell lines. But the most important part is the drug latent space, as I explained. So based on the gene expression response, we can learn a map which shows that which drugs had similar effects and at single cell level. By looking at these, you could see, for example, the drugs with epigenetic regulation mechanism of action or mode of action, they actually tend to cluster together. What you could use this map for is for repurposing approaches. So where you can take 2 drugs and use them for different aspects. We actually validated our method and found out on bulk data, and then we saw that similar drugs are actually clustering together. Also on the prediction side, we showed that the model could find out which cell lines are responsive to which drugs and which are not. So here you see an example of the model that picks up the continuous dose response, and for which it figured out that the cell line is responsive to the drugs in orange and green, but it's not also not it's not responsive to the blue drug. Yeah, and so not just predict the response of the drugs that it has seen, but also pick up the non-responsive drug, which is actually super important. And finally, on drug combinations and also on genetic combination, we applied the model on a data set from Jonathan Weissman's lab, and where they actually measured 287 single and double knockouts. So basically mostly CRISPR-I, so basically overexpression, and then basically CRISPR screens. And then since these kind of experiments are really expensive to do at single cell level, they only managed to basically measure 100 double combinations. And here's the genetic latent space that we actually infer, and it shows that the similar combinations of basically the similar gene knockouts and combination of them could induce similar gene programs, and the model can actually figure out and find out which one of these combinations could lead to a certain gene program. But more importantly, we showed that like if the model hasn't seen a double combination, double knockout, and those could have synergistic or epistatic interactions between them, the model can actually predict the such interactions at single cell level. And you see two examples here where we actually predicted the double combination for two different interaction regimes. But for experimental design, as I mentioned, the single cell experiments are expensive, and it's not easy to basically take them to clinic or do them at scales, or like doing like typical screens, which people do at bulk. So the computational methods are needed to guide experiments. Here, for this data set, we generated all 5,329 missing combinations that the original experiment could not measure. And we predicted all these combinations. Basically, we predicted 50 cells for each missing combination. What you see here, that you see like only small subspace of this genetic manifold were explored in the original data, and we predicted the rest. Just to show you that, I think I'm over time, but like quickly, just to show that for KLF1, which was one of the factors that they measured, we could in silico predict different behaviors in a sense that the model did not see these behaviors, but all the combination that we predicted could show epistasis or dominance or synergistic effects, while the model could not see them. So you can actually use this to narrow down the hypothesis space for the next experiment. And finally, we showed it on cross-species experiments, where you can actually leave out, or we show that if you leave out a species, so this is an example from Sarah Teichmann lab, from macrophages perturbed with LPS in 4 different time points. And we left out both mouse and rat at the highest time point and predicted the effect of gene expression after LPS infection for those 2 species. And we showed that the model can actually predict the species-specific effects at single cell level. So summary, CPA, which is the name of the method, called compositional perturbation autoencoder, allows to decompose variation in latent space, and then compositional model allows to interpretation of these directions, because you could interpret the drug specific or like the perturbation specific manifold. So with this, and also in short outlook, I'll show that like similar perturbations and interventions at single cell level could go beyond just transcriptomic effects, but you can also predict the effects at different levels. So for, let's say, protein abundance after a certain drug, or gene expression, chromatin accessibility, or spatial resolution, basically you can predict what are the cell compositions that would change after a certain drug. Causal modeling is another important aspect which could be followed. And finally, since these are like data-driven models, and these data-driven models are not, so basically they're hungry for data, and if that information is not available in the data, they tend to fail. So one way to compensate for that is incorporating prior knowledge to compensate for the lack of data, which could actually improve the predictions. So with this, I'd like to thank all my collaborators from Ty's lab and then Facebook AI, and then I apologize for the technical issues. Thanks a lot.
Thank you very much, Mo. That was Fantastic, wonderful talk. Super exciting, the possibilities that deep learning and CPA in particular are opening. It's incredible. So yes, we should move to the next, our next and last speaker for the symposium, Istvan Kovac. We are delighted to welcome Istvan Kovac. Istvan is professor in the departments of physics and astronomy at Northwestern University. He's also senior visiting researcher at the Central European University, Department of Network and Data Scientist. Previously, he was a postdoctoral fellow in the Network Science Institute at Northeastern University, a visiting researcher in the Center for Cancer Systems Biology at the Dana-Farber Cancer Institute, and at the University of Toronto. Professor Kovac is working on bridging the gap between structure and function in complex systems. His group is developing novel methodologies to predict the emerging structural and functional patterns in a broad spectrum of problems, ranging from quantum physics to systems biology, in close collaboration with experimental groups. So today, Istvan will be presenting network-based prediction of drug combinations. So Istvan, thank you very much for joining us today, and the floor is yours.
Thank you so much for the kind introduction. It's my pleasure to be here. I hope that you can hear and see me well. So,
perfect.
All right. So the topic for today is drug combinations, and they not only happen at the pairwise level, but there are patients, a large number of them, who also take more than 2 drugs at a time, 3, 4, 5 drugs, or even more. And in a number of cases, there are unexpected side effects which would be nice to avoid, and there might be out there also unknown good combinations that we should actually try in practice. So in my group, one of our dreams is to develop computational methods to get there and tell what happens if you take 5 drugs at a time, and of course you cannot get there without some input data and without some insights about how the biology works. And we have a number of stories that we are working on. Today, I'm going to focus on the first story mostly, where we take a lot of existing knowledge from the literature, like how molecules in our cells interact, how drugs target specific proteins, and which gene is associated to which disease. And some of the resulting methods and predictions have been already published, and but this is still an ongoing direction, but there are additional directions depending on the kind of input data that you take. And in each of those cases, you might need to utilize different kind of mathematical tools to get there. So I will very briefly outline the second approach, and the third approach has been somewhat covered in the previous presentation. So what we mean here is, again, a single cell perturbational input data, and with the right machine learning or network science tools, statistical tools, you can actually use them to predict unknown good or bad adverse effects. All right, so let's dive into the first story. So seeking drug combinations is not an isolated story. There's a broader perspective here. Sometimes we refer to it as network medicine, where you try to use all sorts of input data and how those data sets or perturbations or molecules interact with each other to address specific questions like drug repurposing or personalized medicine questions. And somehow our approach fits into this framework, and we are just building upon these existing tools to get there and eventually tell what happens if someone would accidentally or based on a prescription take like 5 drugs at a time, right? So that's where we are heading. And an important starting point is the existing knowledge about molecular interactions, including signaling networks that you already heard about today. And a major player in this kind of area is protein interactions. So they are often the basis to understand the functional proteins or disease mechanisms, the impact of specific mutations, drug effects, and so on. And it seems that we have a lot of data about this, but we should also be aware that that this is a huge search space. Even if you just consider one protein for each human gene, we are talking about 200 million pairs of proteins that could or could not interact, right? Under some conditions in some cell types, and we are nowhere close to fully explore that space. So it's important to keep in mind that all our existing data sets are very limited. And it's not even a clear theoretical question what can be addressed, answered, and how, based on limited data. So ideally, if someone would give me a list of all the physical, biophysical interactions in our cells, each of the cell lines, and how drugs perturb those, maybe we could build detailed mechanistic models. But the issue is that the data sets are more incomplete than complete, just like we really have a tip of an iceberg, and there are additional issues with every single aspect of the data sets, right? They might be limited, there might be biases and all sorts of missing biology, and then additional factors that we don't take into account. So I'm often asked about what is the right protein-protein interaction network to start with. There is no answer to that question as of now. You need to seek a compromise between data quality and coverage, and it really depends on the final questions that you're trying to address, and it's a really slow and painful process to narrow down what kind of information is the most useful. So I won't get into all those details today. I will focus on concepts, and an important starting point is a 2015 paper and papers around that time showing that genes related to a given disease, most complex diseases or subtypes of cancer, tend to cluster together or form neighborhoods in these molecular interaction networks. I often call them interactomes. So each potato here or circle represents a disease module, a neighborhood that seems to be enriched in disease-related genes for a specific disease. And if this is the case, which seems to be the case according to all our experiences, then you can take this as an insight and ask questions. Are two diseases related if their neighborhoods overlap, their disease modules overlap? Is it true that if two of these disease modules overlap, then a drug that can be used for, again, to cure one disease is also useful for another disease that lives in the same neighborhood? So these are basic questions that have been addressed over time, and this is the starting point to find drug combinations. Before getting to the specific details, let me just outline that even if in reality all disease-related genes would be nicely interacting and forming a nice cluster in a network in a graph theoretic sense, this is not what we see, because there are missing interactions. We don't know all the disease-related genes, and there are biases and additional issues, and the networks are not static. They might be different in each person and in each cell line. So eventually, yeah, it is really a miracle if anything works, starting from data sets like this. And as I mentioned, mutations in patients might perturb the underlying networks, and there is a big ongoing project for many years now. Some of the results have been published, like the reference here, where we are trying to understand how mutations of a patient walking into the clinic affect or perturb their networks in a personalized way. And the one approach to this issue is to collect the rewiring impact of all known or frequently occurring perturbations. And then if someone walks in, we can just look up their impact in a library and then combine all those rewiring events and get a personalized interactome and then run the same methods on top of that. I'm not going to talk more about personalized medicine today. I just wanted to outline that it's possible to not only take generic input data sets, but to really make them personalized. And from now on, I will just pretend that it's enough to look at generic data sets. So imagine that you have a relevant interactome, and as we assume, the diseases tend to cluster in these, form specific neighborhoods. Now you can ask for a specific drug, if it hits the same neighborhood, or whether it's close to a given neighborhood or not. And in a series of papers, it has been shown that drugs that hit the same neighborhood where a given disease lives are really useful to cure that disease, or sometimes actually they might imply like symptoms of a disease or things like that. So the sign is not incorporated in this story, whether the drug is really good against the disease or whether it makes it worse. But if the drug area where it hits the network is far away from a disease module, then we don't expect any specific results, maybe just side effects, right? But it's not going to be efficacious. So that's the baseline starting point. And then there are several mathematical ways based on graph theory, shortest paths to quantify where these disease modules are, whether a drug is hitting a neighborhood or not. And the key point that I wanted to outline, that in contrast to traditional approaches, it's not necessary that a drug directly targets a known disease gene. So you can detect that a drug hits a specific disease module, even if none of the drug targets are known disease genes, right? They just need to be in the same area. So that's a power that might elevate some of the limitations that I mentioned before of missing data, drug target information, protein interactions, because it's enough to have to some extent limited data to detect that there is some signal like this. And proximity of specific drugs to given diseases have been successfully used to predict drug repurposing candidates. But this is an older story, so let's see what we can do for drug combinations. If you have two drugs, then you can again ask the question, are these two drugs hitting the same network neighborhood or not? Is there even a network neighborhood for a given drug? And it seems that the answer is yes to both of those questions. Drugs most of the times hit specific neighborhoods in the networks. Of course, one must be careful because the input data is limited about generalizing these statements, but it seems to be the case that if two drugs are closer in the networks, their modules, drug modules are closer, then they're more similar in all sense. And you see a few examples around here. I'm happy to get into details if there is any question about this. So what happens if you try to use the same concept for drug combination? So the minimum framework that you need to use includes a disease module that's shown in pink, and then at least two drugs, maybe more. And for two drugs, there are 6 possible scenarios that could happen. On the top left, I'm showing an example where both drugs hit the same neighborhood, at least partially, where the disease lives, and they also overlap with each other. And there are several other possibilities. So for any given known example of adverse effects or synergistic drug combinations, you can check which of these categories are seemingly happening. And then if this looks promising, that, for instance, you could imagine that one of these cases, patterns, is mostly capturing synergistic drug combinations, then you could use it to predict further synergistic drug combinations, right? You take 2 random drugs, you look at a specific disease, and if you see that they fall into one of these categories that mostly contains good combinations, then it could be a good combination itself. So that was the idea. And magically, it worked out, even with our limited knowledge about all the ingredients of these networks. So what we, for those mathematically inclined, here are the details of how we calculate proximity between 2 drugs and the drug and the disease. You can look up these details in the references that I already mentioned. I won't spend much time on this. Eventually, the story is that we can quantify if two drugs overlap. So that's the SAB score. It's smaller than 0 if they overlap and larger than equal than 0 if they don't overlap. So drugs are shown in green and yellow. And between a drug and the disease, we need, for mathematical reasons, a different score, a Z-score. And then if it's smaller than 0, then the drug hits the disease neighborhood. If it's larger than 0, it doesn't hit the disease neighborhood. So not too surprisingly, in hindsight, the only 2 patterns that give us meaningful either adverse effects or synergistic combinations are shown here out of 6 combinations. So what you need for either positive or negative combinations is that both drugs need to hit the disease neighborhood. It doesn't mean that any of the drug targets need to be disease genes, right? But they must hit the right neighborhood. And then what we've seen seems to make sense for 2 different kinds of diseases here. So that if the 2 drugs hit the disease from the same direction, maybe by the same mechanism, then you typically have adverse effects. So in a significant number of cases. On the other side, if they somehow act complementarily on the disease, then that's where the synergistic combinations are found. So yeah, I'm showing here some statistics about high blood pressure, and we went up to a few other case studies. So the take-home message is that that both drugs need to hit a disease module, otherwise you shouldn't look for them applied together for a given disease. And if they if they hit the Disney module from opposite angles, if they don't overlap with each other, then you have a chance for meaningful drug combinations. And I have a detailed case study here. It would take a lot of time to fully explain what we see here. For each drug pair, it's color coded whether they fall into the synergistic category or the adverse effect category. And with X's and O's, we show the known combinations or drug combinations or synergistic combinations, and they seem to well align with our predictions. And based on these patterns, we can extend our predictions to the rest of the pairs, all the uncharted territories. And we even went after the mechanisms, and you can really see that the network-based picture that I was showing is well aligned with the mechanistic understanding of how drugs really work. So all these results have been already published, and currently what we are working on is extending these frameworks to more than 2 drugs, and that can be done relatively straightforwardly. The problem is validating those. So if anyone would like to collaborate on that, I'm very much looking forward to an opportunity. So before getting to the last few slides, let me just outline that even if our network data or drug target data is incomplete and there are issues, we can still distill with the right mathematical tools meaningful predictions from a network framework, and we might gain even actionable mechanistic insights even from generic networks. And you can do even better if you personalize your data sets. And for instance, this framework, but other frameworks that I'm going to mention as well, can be extended to higher order drug combinations. And this is something feasible to do nowadays already with current day computers. All right, so the second story is going to be very brief. Imagine that you're not relying on any of my favorite protein interactions or drug target information or disease genes. You want to make predictions without any of that data. Is that even possible? And it turns out that you can do pretty good predictions if you have a knowledge base of how currently administered drugs combine. And here is just an example from DrugBank of some of the most frequently administered drugs, where we also know the drug targets, but that is actually not required. So every single node here is a drug, and you see a blue link between them if there is a known adverse drug interaction. In a significantly higher chance than the random, you see adverse effects. And the few red lines that you see here are synergistic drug combinations. And we asked the question, can you predict more synergistic drug combinations or adverse effects for these drugs, right? Can you extend these links and tell us more? Or is it, and there are additional questions that we went after, like imagine that for a given drug, you only have adverse effects. Can you use the rest of the network to find the synergistic drug combinations? And again, you can do both with very high precision. And here we are showing some computational cross-validation. These are unpublished results, so we are still in an early stage. But it seems that we have about 90% chance, or even higher actually, in current studies, of predicting if a combination is going to be good or bad. So if you forget about half of the data and you try to predict it back, we get the correct predictions in about 99% of the times, which is much better than what we could get based on protein interaction networks, drug target information, all that. And here we are not using any of that. We are just using actual pairs of drugs that work, right? In some sense, either in a bad way or a good way. And once we have this framework fully established, we can combine the two approaches and integrate existing drug combination networks like this with drug target information and molecular interaction networks, and hopefully get even better and meaningful predictions. So for those who are interested in how we do this, there is a current paradigm in social networks of figuring out if a link is positive or negative. You can think about friends and enemies, and we all know that an enemy of my enemy might be my friend. So you can use the same mathematics for drug networks. Bad combinations might be negative links, synergistic combinations might be positive links, but it turns out that this doesn't work as well as in social networks for drugs. You need to extend this triangle-based mathematics into larger patterns, patterns of at least 4 nodes, and that's something that we argued for in a recent paper for generic biological networks. So that's sort of the insight of the mathematics that we are doing here. And what we are really excited about nowadays is to move on and and tell what happens if you take 3 drugs at the same time, or what happens if you combine mutations in cancer or in other diseases, in cell lines, what is their combined emergent pattern. And mathematically, we see analogies between biologically very different questions, like what happens if you want to combine 3 mutations, or 2 impacts of 2 mutations and a drug, or 1 mutation and 2 drugs, or 3 drugs. And we have a generic framework that can hopefully address all these at a similar precision. So that's what we are currently working on. So if you would like to work on any of these directions with us, we're really looking for high quality input data sets and ways to validate our predictions. All right, so I'm going to stop here so that we have time for questions as well. And let me just thank you all for being here, for your attention, for your questions in advance, and all my collaborators. And I only could list some of them here, but I'm hoping that the list will get even longer soon enough.
Thank you, Isfan, for this fantastic talk. Always amazing the power that networks give to solve very complex problem, and the accuracy outcomes you're reporting in this last method, super exciting. So yes, we're reaching almost the end. Should we start now the questions? Please, can the other speakers join in? Yeah, remember that you can put the questions in the tab. So there are many questions. We are kind of late, but I'll try to squeeze some here for Julio first. The first question is, do you think in the near future we might predict the route of the tumor to escape from the drug pressure? If the relapse will occur, is this possible to find a suitable drug combination?
I think it's a very important challenge and it's a good question. And I think it's difficult. And I'll give you an example, something we did a few years ago with somebody, Pedro Cutillas in London, that so they grow cancer cells with increasing amount of drugs. So that's how you also try to simulate the development of resistance. And they did this 3 times, and then the profile with mass spectrometry. And the active pathways were quite different. So meaning, even in a well-controlled experiment where you know, in theory, it's all the same, you have a very random effect that can make you go one way or the other. So I think predicting this is difficult. It's not something we have worked on actively, so I don't have too much experience, but it's certainly important, and I know people are working on this. And I think I mean, to some degree, we'll be able, but there are so many things that are just also stochastic, right? I think there will always be a big variability.
Thank you. So also another attendant is asking, is there a role for induced pluripotent stem cell technologies to help build these predictive models you are developing?
Yeah, iPSCs are really a great system, and they are very good in that, yeah, they come, of course, from patients or people in different ways, and then you can do many more things that you can, I mean, it's a better system than a cell line, right, in many ways. Again, it's not something we have worked on, but I see them as a valid model. So normally when I discuss this kind of how to go from cell lines to patients, I always make this point that there are intermediate models like iPSCs, mouse models, organoids, and they all have strength and weakness. And I think they all have an important role to play in these questions. Yeah.
Perfect, thanks. So I think Isvan and Mo are not available.
I think I could hear you finally. Yeah.
You can? Okay. This is, there we go. Okay.
Yeah. Sorry for the inconvenience.
Okay. So for Mo, there's somebody asking so the efficacy of the deep learning methods is bound to the size and diversity of the training data. So one question is how should we aim to make the cohorts to train this data? Does this methodology you're developing help to decide on what are the technologies and the sample sizes that we should use to really train better these models?
Yeah, I think That's a good thing to mention here, that like these deep learning models, they need a lot of data to actually fit, and the more data that you give them, the knowledge of the model will increase. So the more diversity, let's say if you train with a data set with 2 drugs, so basically, and then predict something for a population missing for those 2 drugs, if you add more drugs and then more populations, so it sees the diversity and the differences between the drugs, it gets better and better. Yeah, so this is important, like to know the limitations, that like you cannot predict unseen effects that you've never seen in the data, so it will basically fail unless it has seen something in that direction. Let's say if you have 2 combinations, A and B, A and then B and C, you can still predict A and C because you've seen the combination of these 2 with other things. But like if another data comes and you have only seen it in like single combination or like a single drug, it's hard to predict it for combination. So it's really important to see the evidence, and this has to be actually put into the experiments when you design experiments. So usually sparser experiments, in a sense that you would have some data, but that would be sparse, is better to not to have those examples in the data, especially for deep learning models. Yeah.
Thank you. So another question. Thank you very much, well, for this really interesting talk. It says, for diseases such as immune diseases, where disease depends on the interaction of the cells between them, do you think that it will be possible someday to expand this type of models to models that can study the combined response of multiple cells? What do you think we need to get there?
Yeah, I think like this is actually a good time to address all those problems, because with the rise of spatial transcriptomic, you can actually measure the cell-to-cell communications and basically check how the cell response will change if the approximate or like the neighbors of the cells are this, or you can basically then spread the neighborhood from like smaller neighborhood to larger neighborhood to see the effect of the neighbors on the prediction. There are also some works from our lab that actually shows that like if the neighborhood information actually affects to predict the gene expression response. But the short question is yes, but I guess it requires combining spatial measurement with multiplexing technology, which we're still not there yet, to basically measure all these perturbations at spatial resolution.
Perfect, thank you. And finally, for Istvan, I have some questions. So the use of network that you've shown to prioritize drug-drug interaction, it's been shown successful in cancer, but it's in the similar direction, no? For example, in another disease like autoimmune diseases, where cell signaling and cell differentiation at the different type of areas are key, and there's a lot of dynamism. Do you think that this type of network modeling will hold and be useful for this approach?
Yeah, that's a good question. We really hope that that will be the case. So the reason why we were focusing on cancer and like hypertension and some of those other diseases was that we have enough data computationally to validate without further experiments our methodology, right? And in the other areas we need experiments, right? And I'm not an experimentalist, so I need collaborators for each specific topic to go after those, and that's the reason why we omitted those. But computationally we don't see any reason why the methods would be worse, right? And we really believe that they distill something fundamental enough that the results will still survive, even if there are additional biological complications. But we will only know if we test them.
Okay, thanks. So another question. Great talk, Istvan. There's a question. I would like to know your opinion about how adding other layers of molecular data can help on refining the definition of disease modules and the impact that this could have on then predicting the drug combinations.
Thank you. That's a very timely question. And okay, you asked my opinion. So my opinion is that we need to be very careful in combining or integrating different data sources, because we've seen like red flags when you do it in a wrong way, that it can really hurt to have more data. Because with more data, you bring in more noise and you also bring in more biases. and it's not clear that in the end you gain something. So one must be very careful and really understand the limitations of each data set and how to relatively weight them or interconnect them. So if you do these things naively, you might even make things worse. And the classic story of that is, what if I include weights in my molecular interaction networks? Like if I take into account which one is stronger or weaker, there's currently no good way to do that so that it helps. It usually just hurts, right? And additional layers of information should in principle help if we are smart enough to make them useful.
Great. So thank you very much. We reached the top of the symposium, and now it's a bit late here in Europe. At least in name of the DocTis Consortium, we would like to thank all the speakers and audience for joining us today. These fantastic presentations that we've been seeing on the challenges of combinational therapies at the clinical and also translational side. And well, we are sure that this will transform how precision medicine will be coming in the next years. If you have any lingering questions, please feel free to reach any one of the speakers. So once again, thank you very much to the speakers and audience for joining us today, and we hope to see you next year on the second Symposium of Combination Therapies in 2022. Take care.
Thanks.
Thanks.